Welcome to the 5 Codes podcast, where we discuss evidence-based methods to elevate yourself to the next level through optimizing the way you look, move, perform, feel, and connect.
This week's OR diary is 2 different things from 2 different patients, one of which is something very interesting that I found and saw, which is kind of unique and novel, and the other one is just an idea worth mentioning. And the story of the thing that I saw that is very unique and novel is today, I'm working through the neck of somebody doing a neck revision, and I found a bunch of filler, hyaluronic acid filler in this patient's neck, down the muscles of the neck, which is not something that I see all the time. I certainly know and see all the time where filler migrates, moves, whatever you want to call it, which is sometimes vehemently denied by the injection community. It was placed there, it was on purpose, it was put in the wrong spot. This is just a straight up situation of the person had lower face filler, chin filler, things like that, and it had quite literally migrated down the muscles of her neck. We were seeing it way down in the musculature of the neck. So anybody who denies that filler moves, if it's placed in there, it's crazy when you see it in real life. There's no way that this person had filler placed in her neck, which is quite interesting. And she had had a previous procedure on her neck that it was non-surgical in the sense of she'd had neck liposuction done in the front part of her neck when she was a little bit younger, which left her kind of feeling hollowed. It was the wrong procedure for her to have in the first place. I often say that. She just had some laxity forming in her neck, and instead of doing the thing that needed to be done, which is lifting and tightening the floor of her mouth and actually elevating the things that had sunk, she'd had liposuction. So when I'm in her neck, now I'm looking at filler in the musculature of her neck, like inside of it, these like globs, these like little gems, diamonds of filler stuck everywhere. I'm also seeing the muscle of her neck that's stuck to the skin above. Because if we think of the purpose of the subcutaneous fat in our neck, meaning the fat that's right under our skin, it's a good thing. That is the insulating layer that allows the musculature of our neck to move in its glide plane and have the skin, kind of move, like not move over the top, be able to glide. It's a natural cleavage plane that's supposed to be there. And that fat is insulating. It kind of takes some of the deep neck contours and makes everything in the neck look soft and youthful. We want the right angles, but we also don't want it to look overly harsh. Removing that fat is misguided because it's usually not what's actually overabundant. It's that other things have sunken. Unless somebody's really heavy with a high body habitus, then it's usually part of the equation, not the whole thing. This is why injectable things like Kybella that are aimed at that fat have flopped and failed. It's why liposuction is often a bad treatment. But for this particular patient, she'd had such aggressive normal, but often liposuction is very aggressive trying to get rid of it, that the fat had been removed between the muscle and the skin, so there was no more glide plane, and the skin and the muscle were getting stuck together, like literally stuck, fibrotic, scarred together, if you will, which creates planes that don't move normally and creates unnatural looks and hollowness and contour irregularities. And so as I'm going to, remove the filler and normalize this patient's neck, the muscle was looking a little bit like Swiss cheese from her previous procedure. And so I'm fixing all these defects in the muscle. I am detaching the muscle from the skin, trying to make everything look normal. So in addition to the filler, I guess, in there, which was sort of a very interesting thing to see, migrated filler, unquestionably migrated filler, it was also quite a bit of revision work to do from a air quoting here, non-surgical procedure in her neck that she had to try to improve her neck that was misguided and had failed her and ultimately led her probably to have surgery in a more urgent fashion than she would have otherwise. So that was very unique. And then with my second patient, the concept that this patient really illustrated was interesting and unique to me. And it was the difference between buccal fat and perioral mounds. And so if I break down what both those things are, buccal fat is a fat pad, as I'm pointing at my cheek here, that lives inside of our cheek around where our teeth are at. So if you were to poke yourself in the cheek and you can poke in between where your teeth meet as you open your teeth, that's the area where this very specific, deep, very unique, very cool and beautiful fat pad lives, called the buccal fat. And that buccal fat is deep. Like when you bite the inside of your cheek, you're biting sort of the housing, the membrane. There's a muscle actually that is the inside lining of where your buccal fat sticks into your cheek. Babies have big, beautiful buccal fat pads, but that buccal fat pad extends all the way up into your temple and around some of the muscles that we use to chew and move our jaw. And over time, because the buccal fat pad is very unique and very deep and it has a different structure to it, it tends to sag, sink, and can cause some bunching around the corner of the mouth, leaving some hollowness back behind where it came from, kind of like a glacier leaving a valley behind it as it moves slowly over time. So a lot of people like to go cut that buccal fat pad out. They'll go access it, which we can do through the inside of the mouth, very, very stealth, essentially scarless to get it, and people will cut it out. But I think a little bit differently, and I argue that we don't want to cut that out because that fat is very important structurally, almost like as a three-dimensional buttress to the rest of the structure of our facial fat, that we want to put it back where it came from. So I have developed and am always improving on a procedure of lifting the buccal fat pad back into space. This is a theme of my overall practices. I very rarely am cutting things out and throwing them away. I'm usually putting them back where they came from, and the buccal fat pad is no exception to that whatsoever. I am restructuring the space. I'm using the volume that's there to redistribute. I want to recreate things the way that they were. I don't want to transform anything to the way that it wasn't. And so buccal fat pad fits very, very much into that. But that can be very confusing to some surgeons and especially to patients into what some of the mounds or contours they have around the corners of their mouth are. Because some of the fullness that can form around the corners of your mouth, around your smile lines, underneath your lip, above your lip, wherever it may be, are not all from the buccal fat pad. They can be mounds that form from bulks of musculature, from the way things have descended, from how our muscles uniquely pull on our fat pads in our skin. And so it really needs to be delineated as to what's actually happening in an area and how we can correct it. And the patient that I am really referring to who sparked this story had her buccal fat pad removed, which makes me cringe inside because she's in her 50s, and removing her buccal fat pad was not the answer. Even if it was the culprit, it should have been lifted, in my opinion. But what she had was a perioral mound. It had nothing to do with her buccal fat pad in the first place. She already was a little bit thin in her buccal fat. Not everybody has excess buccal fat that's mounding around their mouth and causing gravity. A lot of times, I'm trying to restore the structure from the buccal space from a fat pad that is actually shrunken away, which I do with my very unique blend of stem cell-rich fat transfer. But for this particular patient, not only did she already have a small, hollow buccal space that was creating some almost aging and structural irregularity in her face, but she had some perioral mounds that were confused for buccal fat. So the buccal fat pad she did have was further removed by a past procedure, which creates a very unique environment with a kind of an updating surgical procedure that we were doing, where this became a small but important component of her overall facial rejuvenation, because we're trying to, number one, take care of the perioral mounds that led her to seek treatment in the first place. I'm trying to restore the damage essentially that was done to her buccal space, so the subtraction that was done by restoring it, in addition to doing what she needed done in the first place there, and restoring her overall facial architecture with the rest of our procedure. This is very common for me. It's not one thing that we're after. It's a full facial rejuvenation, but this became a very important part of it. And it helps me understand the amount of confusion and misunderstanding that exists between what is a perioral mound and a buccal fat pad, which gets really nerdy and really detailed and really into the weeds, but also helps illustrate how important it is that whoever you are choosing to have this procedure with is digging in to the weeds, getting into the esoteric, is curious, understands what's happening on a deep, deep level with the buccal fat pad, quite literally the deepest fat pad level of our face, and is doing things not just because they can, but because they should, with a deep understanding of that. So I love that. I talk to my kids about that all the time. Just because you can doesn't mean you should. What are the levers that we need to pull? What's causing what we're after? What's our best way to maintain harmony? And then, of course, do all that in a way that nobody ever knows that you had something done in the first place. So you can look in the mirror and see that thing that you want to be seeing, erasing that cognitive dissonance. So oftentimes the area around the mouth is big for that, and that taps into our neuroanatomy, neurobiology. We know that the area around the mouth is wildly important for our nonverbal communication and what we're putting out into the world, and the buccal fat pad and the perioral mounds are very, very key parts of that.
If you have any questions or topics you would like me to explore further, please leave them in the comments. I read them all, and they often help shape the future conversations here. If you would like to learn more about my surgical practice, you can visit clinic5c.com, where you will find additional information on my approach to surgery, recovery, and performance-focused care. I also want to be clear that the views shared on this podcast are my own and are not associated with or representative of my clinical teaching affiliation with the University of Washington School of Medicine, nor should this be taken as individual medical advice. Thank you for spending your time with me. I appreciate you being here, and I will see you on the next episode.